going to increase the number of colonoscopies with a positive finding. So bring the patients in that aren't getting screened today into the pool, but also the patients that would require a colonoscopy because they have some sort of positive finding will be the ones that are going through for a colonoscopy.
Dr. Haytham Gareer, thank you so much for joining the Scope Forward show. I've been looking forward to having this conversation for a long time now. We're going to be chatting about RNA tool tests, and I can't be more excited to learn more.
Thank you. I appreciate it. I appreciate you taking the time, and I look forward to having our dialogue and our conversation this morning. So excited to be here.
Excellent. Let me start by outlining your bio for everyone. So Dr. Haytham Gareer is currently the Chief Medical Officer of Geneoscopy. He's responsible for leading clinical research efforts, collaborations with key medical advisors and professional societies, and providing critical insights to support commercialization and technology development across the company's pipeline of products. Prior to joining Geneoscopy, Dr. Gareer served as VP Global Head of Medical and Clinical Affairs for Olympus. Dr. Gareer is an endoscopist with international experience. He's received his MD in surgical oncology from Cairo University National Cancer Institute in Egypt, a PhD in surgical sciences and hepatobiliary and pancreatic illnesses from University of Verona, Italy. He holds a master's in minimal invasive surgical technology from Italy as well, an MBA from Hult International Business School, and a master's in applied healthcare economics and outcomes research from Jefferson University. That's quite a bit of an educational background and an expansive career spread, and that to a global one. Is there anything remaining that you would be studying, Haytham, from this point? Are you going to be studying more?
Well, I'm considering law school, but it's a little bit of a stretch. No, I think what this all kind of came together nicely. It's just the medical experience combined with the business and the applications of medical knowledge in the medical domain in both the medical device and diagnostics. So the education helped move this forward and drive this forward, so that my ability to contribute to some of the work that's happening in the industry was supported well by this education. So it all came together nicely, I think.
So you joined Geneoscopy as its Chief Medical Officer in October 2021. And the next month, the company raised $105 million from various investors to advance stool-based RNA tests. So tell us about it. Tell us about the company and about the product pipeline. How did it get started, and how did you end up joining them?
Yeah, absolutely. So Geneoscopy was founded in 2017 by the Barnell siblings, Dr. Erica Barnell and Andrew Barnell. They really were the ones that started the company and that helped develop and build it to where it is today. Erica was a PhD student at the time, and she uncovered the potential of RNA and really the proprietary technology behind being able to isolate the human RNA from stool and isolate that from all the bacterial noise and bacterial RNA, and be able to harness that power to interrogate the RNA and be able to identify several disease states. And the primary focus they decided at the time would be on colorectal cancer screening. So be able to identify the RNA biomarkers in stool and really be able to detect colorectal cancer at an early stage. And we can certainly talk a little bit, in more detail, but the company started with funding from family and friends, as they called it at the time, and didn't really have a lot of capacity. There was no facilities or anything like that. They were really, at the time, it was Erica, Andrew, and Yiming, who was the software engineer or the brains behind developing that algorithm that feeds into this assay helps feed into. The company has grown since, and there's a lot of progress. And as you mentioned, after going through a Series A and Series B, they were able to raise about $150 million with a lot more recognition from key investors, strategic investors, and also most recently, they were able to get CLIA certified. So the lab is CLIA certified. It's over 11,000 square foot lab in St. Louis, Missouri, where the company's based, where both founders, Eric and Andrew, grew up. And this is the headquarters for now for the company.
That's awesome. Let's start with the science. Tell us about what exactly the product is about. What does it do? And you mentioned one of the first people to come aboard was a technical person. So, what exactly did he or she build? Tell us a little more about the platform.
So, as I mentioned, I think the essay is focused around being able to harness and identify RNA biomarkers in stool. RNA plays an integral role in tumorigenesis, the development of cancer, right? So its role in cellular processes, including proliferation, differentiation, and apoptosis, which allows for the development of proteins that then would be identified as part of the cancer development process, is really the power behind RNA and how it is able to detect cancer and precancerous lesions at an early stage. While the analysis of RNA in stool has been extremely challenging in the past due to the nature of RNA being extremely easily degraded and being masked by the high bacterial burden in stool, the ability to identify and isolate those biomarkers, those RNA biomarkers, is really what this technology is about. And so this assay, the first test that the company's developing and we're currently close to bringing to market, is focused around isolating or combining the 8 stool-derived human RNA biomarkers, combining them with certain patient demographics, like the smoking status of a patient, as well as the fecal immunochemical test results. And that combination, based on an algorithm, would then help with a high degree of sensitivity detect colorectal cancer, advanced adenomas, and also precancerous adenomas.
Did the founders go after stool RNA test for colorectal cancer, or did it just come about? Were they researching for something else, and did this come about?
I think the potential, as I mentioned, of RNA is very vast. The focus on colorectal cancer is just the beginning. So there's potential for additional applications, and it was just felt because of the potential. As you know, colorectal cancer is a disease that is preventable if diagnosed early and treated. So the social impact of this test, the potential application of this test, and the indicated target population that would be best served by a colorectal cancer screening assay seemed like the ideal first step to move forward with this. There are other applications, certainly, and we can also briefly touch on that if you'd like. But really, the colorectal cancer assay seemed like the ideal first test for this technology.
If you have to explain, as you would to a 10-year-old, how would you define RNA, and what is the difference between RNA and DNA?
So the RNA is really, again, as I mentioned, it is really part of the regulatory, or it regulates the cellular processes. So it's part of the pathway that is associated with the initiation and progression of several cancers, while DNA is really an indicator of the presence of cancer. The ability of RNA to be detected in certain tissues like stool, and primarily why stool is ideal here is because the colonic mucosa exfoliates colonocytes that would then be shed into the lumen and accumulated in stool. And those human colonocytes, this eukaryotic RNA present in those cells, we are able to isolate that and identify at what stage in the progression of cancer that patient is, and so be able to differentiate whether this patient is at a precancerous stage with a much higher sensitivity and specificity to DNA. So currently, our initial clinical study, just to give an idea of what that means differentially or in a clinical setting, what the known precursor for colorectal cancer in most cases is an adenoma, right, or an advanced adenoma. With a higher degree of sensitivity, RNA is able to detect advanced adenomas in patients than DNA. And our first study indicated that there's compared to DNA, we have a sensitivity of about 62% versus 42% with current DNA stool tests. So we're able to detect more advanced adenomas and potentially detecting cancer or these precancerous lesions in an early stage. So we're able to impact the prevention of colorectal cancer more. And this is really the power of RNA and the power of our assays to be able to detect more of these precancerous lesions than a DNA platform would.
Are you saying that it is way better than stool DNA tests and perhaps a FIT test?
At the end of the day, it's really the clinical characteristics of the test and how it's able to detect and differentiate the different types of lesions, right? And because of that, it's the higher sensitivity of advanced rate of detecting those adenomas for both against both DNA and FIT is much higher. So there is a superiority element in that particular aspect of precancerous lesion detection.
Now, this clinical study that you've conducted and are conducting, CRC Prevent, can you share what you've learned so far from it and what is the purpose of the study?
It's our pivotal study. The intent is to move this forward as part of our PMA submission to the FDA to get the product approved on the market. This is a 10,000 patient study that we've begun about a year ago and we're close to completing now. It has a very, relatively a very high, very rapid rate of enrollment. It also had a very high diversity inclusion of the target patient populations. And the reason for that, it was a decentralized clinical study approach. I think we're one of the very few initial companies to apply that. So as opposed to working in a traditional setting where we work with sites specifically to patients and follow up, we used a decentralized approach. We reached out to patients through social media to be able to recruit them and include them as part of the study. What that meant is really reaching out to a very diverse and geographically spread patient population. So the study is very representative of the intended target population of the United States, where we were able to include a very diverse racial and racially diverse, socially economically diverse. We were able to include patients from several statuses, including low income. And what we learned from this is really being able to understand a little bit more about the demographics of who gets screened and how they get screened. We were also able to learn a little bit more about the test currently and how the process would work. And we can also talk about how we're going to commercialize this, but this is more or less the same approach. The results were still unblinded. To the results of the study, we won't be able to speak until mid or late August, but we believe it will be as promising as our pilot study with the targets that I mentioned, the 62% and 95% sensitivity for advanced adenomas and colorectal cancer, respectively.
So when is commercialization? When would the product launch and be available for patients to perhaps buy directly online or get a prescription from their doctors?
The intent is for it to be commercially available in Q1 or Q2 of 2023.
Haytham, what is the business model for the company? Are you going to be selling directly to consumers? What's the plan?
We're currently really ironing out the full process, but it would be a very similar process to the non-invasive tests that are currently available on the market. It will be prescribed by the patient's primary care physician or gastroenterologist. We would receive the order and ship out the kit to the patient's home, where then in the box would include a return label. So the patient would deposit the sample, and then it would be shipped back to our CLIA-certified laboratory, where a test is conducted, and the report is sent back out to the physician. And obviously, if a test is positive or there are abnormal findings on the test, the patient would be asked to schedule a follow-up colonoscopy. We're working to ensure that our test we're not just focused on the kit or the product itself, but also incorporating a comprehensive solution that would include patient education, that would include patient navigation through the process, to ensure that the two-step screening test of a non-invasive test and a potential colonoscopy is followed through as part of our process. So it really the component of a comprehensive colorectal cancer solution We're also looking into potentially including a telemedicine approach. We're still working on the details for that, but that would potentially be another option.
Back to the business model, who do you see as competition for genoscopy?
I mean, certainly the prevalence of the other non-invasive stool tests is something to consider. We think of ourselves as a second generation non-invasive stool test. It's something that would add definitely an incremental value to the non-invasive screening strategies that are out there in the market. It's another option that physicians and patients could be offered. With our improved sensitivity for advanced adenomas, we think, again, as I mentioned, there's a differentiator against the other non-invasive stool tests, definitely much better than the FIT test, and definitely there's an incremental improvement over the DNA stool test. There's also potential for, there's what's happening with the entrance, sort of the blood tests. We think that overall our cost effectiveness and the navigation, the colorectal cancer screening solution that we're offering would position us really well against those different non-invasive screening alternatives for colorectal cancer.
Let's talk about that. So you're saying that even if liquid biopsy, as they call it, were to become a reality in the future, you don't see that as coming in the way with what you're building here. What I want to ask is, if a single blood test or a blood sample can detect 15 different types of cancers, as some of these companies are working on. Now, here is your test working with stool RNA focused on one type of cancer. Don't you see that as some kind of a business threat?
There is definitely something to consider there and something to think through. So apart from, the cost implications, and, I'm not going to go into that in great detail, but there are associated costs with a lot of this unnecessary testing and this unnecessary screening and what it means beyond just that initial non-invasive test. The focus on one cancer or what our test offers really is, again, because of the nature of the test, because of its ability to come close to the tumor and the pre-tumoral tissue in stool, where at a very early stage, before the cancer spreads beyond the walls or the layers of the colon to reach the bloodstream, it is still localized and limited to the colon. And because of the nature of the stool and how it allows for accumulating the exfoliated colonic cells, as I mentioned, it's able to detect or pick up on these very early localized lesions much better than blood. So if blood is the option for treating this disease or managing and preventing this very preventable disease, there's a very high chance that you will be missing on these pre-invasive, precancerous lesions, right? So picking up on those in precancerous, advanced, or adenomas in the colon, as an example, is really what would make this test a whole lot better. You would follow patients differently. You would follow the patients and manage them in a much better and more focused approach than would a liquid biopsy.
So should Cologuard be worried about you?
I mean, there's always a concern when there's, if you market entrance, right? If someone else is coming in a general sense, there's an opportunity for someone to challenge what's been around for a while. There should be some thought around a new entrant, right? And to some degree, there should be some consideration now that the market is, and it's just not just us. Again, we just talked about the blood test, so there'll be more competition, obviously, and there'll be more players in the market. So definitely there needs to be rethinking.
I'm taking away that gastroenterologists should definitely be worried about you, the stool DNA tests, the liquid biopsy tests, and so on, shouldn't they?
We really think that our test is actually going to add a lot of synergies to colonoscopy and will add a lot of value to, the focus is really that there are, that there's a good percentage of patients that are eligible for colorectal screening that aren't getting screened. That's number one. So there's about, the compliance rate is about 60%, right? And then there's a lot of patients who would benefit from screening that aren't getting screened. So introducing another non-invasive option onto the market that would allow patients an additional option, another opportunity to get a non-invasive stool or a non-invasive screening test. And those patients, those 40% or so, would not have gone for a colonoscopy anyway. It's just we're targeting those patients, bringing them into the pool of patients that are going to get screened. That's number one. Number two, because of, as I mentioned, our test's ability to detect advanced adenomas with a higher sensitivity, we have looked into modeling studies in health cost effectiveness, health economic models. We see that our test would actually increase the number of colonoscopies being performed. We're going to increase the number of colonoscopies with a positive finding. So bring the patients in that aren't getting screened today into the pool, but also the patients that would require a colonoscopy because they have some sort of positive finding will be the ones that are going through for a colonoscopy. The third value is really because of that, where it becomes a more targeted approach to some degree, where because of the COVID-19 and the backlog and the issues with getting patients adequately in for a colonoscopy in time, you have a population of patients very well behind, and you can't screen everyone or bring everyone back at the right time. A test like ours that would allow for more, I wouldn't say selective, but at least making sure that the patients that are being offered a colonoscopy are the ones that are in need of a colonoscopy because of an abnormal finding. Again, it adds value to the GI's practice. So we think actually, we're here for the GI, we're here for the patient, we're here for the provider, the primary care. It's not a test that's going to take away from anyone. It actually will add value to all the healthcare stakeholders from what we see, right? And this is how we're trying to position it.
I understand from a broader general perspective, but I want to read something, from your website, under the study, which I found quite interesting. You say it's in a clinical study when compared against the gold standard colonoscopy. Our RNA-based platform demonstrated better sensitivity data in detecting advanced adenomas and colorectal cancer than that generated by any other available non-invasive test in their respective clinical studies. So, which is what you've been saying. I hang around a lot with gastroenterologists in private practice, and all that they dream about is screening colonoscopies. At least the last 15 years, that's been the case. Productivity numbers, the quality metrics, everything is set on ADRs, adenoma detection rate, and so on. Now, here comes a test in 2023 that's going to even do the ADRs. I mean, they don't have to do this, right? They don't have to do the screening. It's about 25, 30, 40% of what a typical private practice does, depending upon how interested they are in doing other stuff in GI. But again, just very openly and directly, Haytham, I'm curious you're an endoscopist, so I'm curious to know your views.
Well, so I think you're absolutely right. Like adenoma detection rates, and there are certain quality metrics for colonoscopy that drive the outcomes of colonoscopy. We think our test, if there's a positive non-invasive stool test, be it our test or any of the other tests out there, that this is potentially going to impact the quality metrics of a colonoscopy, just generally speaking. So this can improve a colonoscopy if the physician is unblinded or is aware of the results of a positive stool test. There's an opportunity to improve the colonoscopic procedure, right? Potentially improving things like withdrawal times and potentially even adenoma detection rates, more meticulous examination, right? These tests will allow for that. It's offering to those patients that are not willing to undergo a colonoscopy this other option. Then if they have an abnormal finding, they're going to come in for that colonoscopy, which is really what they need, right? So it's avoiding the unnecessary colonoscopy, but it's also ensuring that patients that aren't getting screened are those that are actually benefiting from a colonoscopy.
I get the point that it's going to expand the number of people who would go through a test because it is non-invasive, and now they have more options. I totally get that. Even as you're narrating this, I'm thinking even someone like a Medtronic that has an AI product should be worried about a test like this, because here's the AI trying to compete with the GIs in trying to detect or classify polyps and identify polyps and the adenomas, right?
Right.
So you don't even have to do that if the test itself is identifying the adenomas with a fair degree of sensitivity. Is my understanding correct?
If the test is negative, right, the patient will not require a colonoscopy. If the test is positive or abnormal, the patient will have to undergo a colonoscopy. The procedure itself would still benefit, the colonoscopy procedure itself would still benefit from enhanced technologies like AI and the ability to detect and differentiate lesions, right? Because at the end of the day, there's going to be still some therapeutic element, right? So that polyp needs to be removed or that lesion needs to be resected. We're not at a point where we can say one is taking away from the other. The way I see it is that it's all adding value. You're increasing the pool of patients that are getting screened. The patients that require screening are benefiting from a more focused approach and more, benefiting more from that colonoscopy. Adding enhanced imaging technologies and other technologies that would improve the colonoscopic procedure itself is still beneficial to the patient. So I think that all feeds into an enhanced continuum of care, better improvement for overall outcomes, right? Again, we're all focused on one thing, is detecting this disease early, treating and making sure that we're managing it early to prevent it from developing into something that is going to be more burdensome.
Some endoscopists that I've spoken to, when I ask this kind of a question, saying that, wouldn't your bread and butter colonoscopy be threatened? They very rightly compare the trend to ERCPs. Like, so earlier, so you don't do any more diagnostic, it's all therapeutic. And that's what I heard you just say. So we don't have to do diagnostic.
Exactly.
Colonoscopy, and that should be a good thing if the market or the endoscopy market or gastroenterologists embrace that. Then they scope forward, as I like to say, they move forward. If they don't, then I can't see how they will not be disrupted. It's just not about you, right? There are a flurry of companies in this space trying to take different approaches to solve this problem. So before I get to my next question, I'm curious, how do you use machine learning in the product, in the company? What role does it play? What do you do with this data? What does machine learning algorithms do with this data?
Don't know if I can speak to the exact details, but I mentioned just the algorithm that we're utilizing. It's fed the information on the 8 RNA biomarkers, the demographic status of the patient, so smoking history, as well as the results of the FIT test. And what that does, it provides, based on thresholds for all these inputs, it generates a binary report, right? It's either abnormal or negative, as we currently have it. So this is how this approach works. I don't know if your next question is about AI specifically or how, but there isn't, I think, this is my kind of perceptive, right? It's just the thinking ahead, maybe, scoping forward, it's just the thought that maybe there are synergies there, right, between a test like this and AI learning algorithms that are being developed for colonoscopy, right? Could this add value? That's something that if they play together, if you merge those two approaches, the positive non-invasive test with the procedure itself, can the results be merged? Potentially, but I don't know currently if that's an option. Today, our test just uses these inputs and provides the algorithm provides a binary output for the test result.
Yeah, no, the reason I asked that question first was because my assumption would be that with more data, the tests would get more sophisticated.
Mm-hmm.
Broadly, the space comes under digital biology. And for me, digital biology would come under exponential technologies. And if you look back at any of the exponential technologies, for example, I sat in a self-driving car back in 2012. And at that time, it was a research project. I was in the Bay Area, and it was a Google car, and the laptop was connected to the steering wheel with wires going all around, and the LiDAR scanner on top was this huge, and it was all bulky. But now, it's more than a reality. So my take has always been that you give digital biology a few years, and because of more data, because of the number of tests that, for example, Cologuard has screened about 3.5 million plus people the last time I took a look at that. I'm sure you would go down that path. You would get all this data. And with this data, there would be more analysis. And with the machine learning algorithms, it's going to be able to predict. I mean, I don't think that it's going to be remotely any competition with the ability of a human being to predict. Screening, I can understand, because it's a sophisticated skill and an art. But this is a prediction. You would be able to predict things that I don't think we'd be able to do in the traditional colonoscopy approaches. What do you think?
No, I completely agree. I think you're absolutely right. As the more we learn about this, the more we learn about the power of RNA. And as I mentioned, this is not just a test. We consider this a platform. So because the potential for utilizing this test is different for even higher risk cancers, for other disease states, for other GI technology, there's always going to be an opportunity to learn how there'll be different iterations of this test to begin with. So this ability to develop the test even further and enhance the sensitivity and specificity from where it is today, but also the applications with other disease states and how it interacts with different disease states and that can lead to cancer. So you're absolutely right. I think the potential for it to grow and expand and evolve beyond where we are today, leveraging machine learning algorithms, is definitely a possibility.
In your knowledge, how many such companies are there? Like, in broadly playing in the space, DNA testing, RNA testing, not just with GI, but medicine in general. Are we talking 100? Are we talking 1,000? Like, what would be your guess?
In the hundreds. The space is evolving rapidly. The ability to focus on molecular biomarkers and tests in general is something that is advancing as the technology for sequencing and everything that feeds into this industry is improving and enhancing. There's definitely an improved threshold for detecting at a much earlier stage, more advanced stage. I think the focus is also very broad across different disease states. So it's not necessarily all focused on just GI or colorectal cancer specifically. I think there's a play for lung cancer, bladder cancer, other disease states as well that are not necessarily immediate correlated to oncology, as well as being able to follow up patients and predict. So the focus is not always on screening. There are companies out there or technologies out there that are focused on monitoring for residual disease, looking at prognostic indicators, monitoring therapies. And so there's a lot that's being done in this space, and I think it's expanding rapidly, and it's ultimately good for everyone. It's good for patients, it's good for therapeutic development, it's good for the healthcare system in general, that these technologies are being picked up and coming into play. But the focus is diverse, which is also good, right? So we're focused on GI health primarily, and we think that our technology, the RNA technology, will play a huge part in that space. With DNA and proteins and the other biomarkers that are being utilized, there's opportunity for other things. And companies, I would say, in the hundreds, which is good.
What are investors thinking? They've invested a significant sum of money. What are they thinking? What do they know?
While colorectal cancer is really what we're selling on our focus, there's an opportunity for pipeline development as well. And this is really what we try to highlight, that there's a next, there's more than just colorectal cancer or the potential for that with our RNA platform. But the promise of colorectal cancer itself is great, right? The ability to benefit this vast patient population that needs to be adequately screened, the gaps in compliance and being able to detect with a better sensitivity the precancerous lesion. I think this is all a great selling point to investors. The fact that we're addressing this disease state is good and it's very appealing, but also the potential of the RNA platform, we believe, is also going to be very appealing in its potential for high-risk patients, for other disease states, as I mentioned, like inflammatory bowel disease and others. And also the applications with being utilized as a companion diagnostic. So the utilization of this test to help even develop therapeutic drugs and other things. There's a whole lot that we can offer with this platform that is potentially very appealing to the investor community.
If you were to advise a GI fellow, what would you tell him or her? There are crossroads, right? Like, so what to do with their career over the next 30, 40 years? Like, so from that standpoint, yes. Given what given what about where things are going, about where things are, and so on.
I'll try to be very, broad, but because it's very general. But I think medicine is now, it's It's very interdependent on a lot of things. The domain knowledge of medicine, understanding about diseases, pathologies, and managing patients, and being able to be that bedside physician where you're caring for the patient directly and following up. But there is an opportunity now, I think more so than ever, and I've been part of this as kind of my career is the technology component, right? And technology can have multiple avenues. It's not necessarily just focusing on, for instance, the scope or imaging technologies, but things like what we're discussing here now, the technologies that leverage even molecular genomics and in being able to help predict where patients can be managed better. So I guess to be open-minded about the practice of medicine, that it's not just focused on what you can learn, or it's not just the medical and clinical knowledge, but there's an opportunity to be more broadly focused on what's next, what the technologies can bring in, how they can benefit that. So nothing threatens the practice of medicine, but I think everything expands and improves outcomes ultimately. So to be focused on and open-minded about what's coming, what's next, and be well-informed on the advances and everything beyond just the practice of medicine, but technology around you, because everything's coming together, right? We talk about AI, we talk about wearable technology, we talk about integrating patient information and data into the cloud. So there's a lot that needs to come together into play. And the more informed the physician, the more informed the GI, the better they're able to stay up to speed and manage patients better.
This naturally segues us into my final question, which is on the future of gastroenterology. So if you have to look ahead 5 years and then 10 years, what do you see?
I mean, we talked about it briefly, and this is my perspective. I think there'll be more and more of a need of the advanced interventional therapies, right? The role of the GI. I'm specifically talking about the endoscopy space, right? The colonoscopy endoscopy space. There's definitely going to be more and more of a trend towards focusing on the therapeutic, the early stage management of diseases. The early you identify diseases, the more amenable are to early treatment and early cure, better managing patients based on a precision medicine or precision surgery approach, right? You focus more on what the disease is at what stage and being able to manage that early on and control it. So I think, we talked about it's not going to be always the screening, right? We're going to rely less and less on the ability to use invasive procedures. In general, this has been like the trend over the past few decades, less invasive procedures for diagnosis and even less invasive procedures for therapeutics, right? So I think to be able to stay on top of that and focus on technologies that would better serve the therapeutic component of the practice is going to be very important. That includes AI, that includes robotics, that includes endoscopy suite ecosystem, integrating imaging, integrating information, integrating big data, and all that into the endoscopy suite. Essentially, I see that heading that direction. A more informed GI, highly precise, more precision-focused management of patients and better care.
Dr. Haytham Gareer, thank you so much for spending your morning on the Scope Forward show. I learned a lot, from this interview, and it validated a lot of assumptions that I've been having. And thanks so much for sharing your perspective, being open, about playing and going in the direction that I was going. But thoroughly enjoyed this conversation. Thank you so much.
Thank you so much. I really enjoyed this too, and hope this is useful, and look forward to staying in touch with you in the future. Thank you. I'm always interested in what you have to offer. So it was great to speak to you this morning.